Good afternoon. This is Dr. Indu Shankar. Welcome you all on behalf of our esteemed DCI President, Dr. Dibyendu Majumdar, Secretary Dr. Sabyasachi Saha, and the team DCI to this 8th webinar today, that is Medical History Influencing Implant Outcomes and Digital Technology in Implantology. It has been a commendable effort on the part of the Dental Council of India to organize these learning and knowledge sharing platforms, the success of which is evident from the steady rise in the number of participants from the country and abroad. Thanks to the effort of our esteemed President, Secretary, and the whole team of the Dental Council of India for organizing these flawless events. Now, welcome to you all, and this has been a customary to give some instruction to the attendees. Now, while registering for the webinar, please furnish your correct email IDs for e-dispatch of your attendance certificates, as many often problems are being faced for wrong email IDs. In case you don't get your certificates in your regular inboxes, please do not forget to check your junk mailboxes, because sometimes the mail may get lost into your junk email. Please note that to get the attendance certificate, the entire session has to be attended uninterruptedly. Now, though we have a huge number of participants from many colleges, the highest attendance from colleges are listed. The highest attendance in order was first with the Sardar Patra Postgraduate Institute of Dental and Medical Sciences, Lucknow. In sequence, they are Siddhapur Dental College and Hospital, Gujarat; NIMS Dental College and Hospital, Jaipur; Indraprastha Dental College and Hospital, Ghaziabad; Vishnu Dental College, Bhimavaram, and Andhra Pradesh. Now, today's webinar is on dental implantology, which is the current demand in dentistry and the choice of most postgraduates, practitioners, researchers, and academicians. The discussion have two parts. The first part is in the medical history, which many times has been overlooked or very lightly taken. The second part is the digital imaging, which have taken a very important share in the today's treatment planning. This is a very hot topic and soon will be covered by our speaker of today, Dr. Gunashilan Rajan. He is a well-known oral maxillofacial surgeon and implantologist in the country, based at Chennai. He has both medical and dental qualification and is a fellow of Royal College of Surgeons, England. Besides being a oral maxillofacial surgeon of par excellence, he is a researcher, academician, and scientist as well. He has been awarded with Scientist Award by the Tamil Nadu government in 2002. His journey on the field of oral maxillofacial surgery is long, and his success story is difficult to be enumerated within this short time in this webinar. He has a high legacy with him as well. He is the worthy son of the late Dr. B.P. Rajan, our past DCI president and the second vice chancellor of Tamil Nadu MGR Medical University. He is the first vice chancellor in the country from the dental fraternity to hold this post. Presently, he is the director of Rajan Dental Institute. Now, welcome Dr. Gunashilan. The screen is now yours. Please.
Thank you very much, Dr. Indu Shankar, for those kind words of introduction. And also thank you very much for remembering my illustrious father. It's nice to see people remembered for their contribution to our profession. and also as a Vice Chancellor of the Medical University. Thank you very much for remembering him. I'd like to start my topic today, medical history influencing implant outcomes and digital technology in implantology. I'm going to break it up into two parts, but I'd certainly like to start with the physician's prayer, because we should look at the patient as a whole and not just as an oral cavity and teeth. Remember this prayer from Sir Robert Hutchison: from inability to let well alone, too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases. This is something I really don't like. Refer to the patient with his name or her name rather than as cases. And certainly, finally, making the cure of the disease more grievous than endurance. Good Lord, deliver us. I think please keep this in mind at every time when you're going to treat a patient. I'm looking at two extremes. One is a medical history, which is where we all have to start. And then at the other end is a final prosthesis. So what is in between is the evidence-based decisions, because today we have science and technology with us. We need to look at the evidence-based decisions using high-end technology, which leads to precision and certainly the safety of the patient. So the importance of using technology and to make it precise and safe is the whole goal of today's treatment. So let me start with the medical history, and then we'll go to the second part, which is the digital technology. We have gone past the era just to give a new tooth, or do you want to give a new smile, or do you want to give a patient a gift of a new life? Now, people may say, what is this? How is this possible using implants? We only think you can give a new tooth or a new smile. How can you gift a new life? Look at this patient. You're not giving this patient just teeth. A young girl like this, who's about 18, 19, you're completely restored her life and her confidence in life. So that's the importance of implantology today. We're not just restoring teeth. We're looking at the patient as a whole and giving them back. I'm going to run through a small video so that you get a feel of what we mean by implantology. So here we are using a surgical stent, which is tooth-based, and then using it to start the first part of the implant placement. So once you remove the stent, then you can see that we are placing the first implant and then using a direction indicator in place and then placing the next implant. So with the digital planning, which I will allude to later, you can see how this can become much more precise and much more predictable and much safer from the patient point of view. Let's go to the medical history now. I'm going to take it in terms of the common disorders that you see, the common medical issues. The commonest issue that you will see in your practice, I'm sure most of you see patients who are diabetic. The problem is we need to have a common sort of score to see what is the status of the diabetes and how can that be influencing your treatment for implantology. The HbA1c is a very common denominator because it gives you the 3 months average control. And when we say good control, it means the HbA1c is between 6.1 and 8. If it's moderate control, it is 8.1 to 10. And if it's poor control, the HbA1c is over 10. So we need to have some sort of a uniform guideline so that when we talk to one another, we understand what each one is saying. So some of you can make note of this reference because this came out as a very important guideline as how would you treat these diabetic patients when they come for implantology. When the patient has good control of diabetes, implants are predictable. That's the important thing. When a patient has good control of diabetes, implants are as predictable as a normal person. When they have poor control, you have all these problems of impaired osseointegration, higher risk of peri-implantitis, and a higher failure rate. So when they are diabetic and they are poorly or moderately controlled, it's better to delay the loading of the implants, usually after about 1 year of healing. You do not do what's called immediate loading. You give 1 year time for osseointegration and soft tissue integration and only then load these implants. This is a much safer way of handling patients who are diabetic, moderately poorly controlled. The whole issue is, it means diabetic patient diabetes does not preclude you from treating those patients. However, we need to be very clear about the control and how well controlled it is, and accordingly change your treatment plan. In such patients, especially diabetic patients, the use of antibiotics and a preoperative chlorhexidine is very helpful. Now look at this study which showed the survival rate when chlorhexidine was used and when it was not used, a difference of almost 10%. Now this is very important, a very simple thing like using a chlorhexidine mouth rinse. I'm sure most of you are using these mouth rinses today in these COVID days, giving a preoperative rinse with chlorhexidine or povidone iodine. A simple thing like that has shown to make a 10% difference in survival rate. So please follow these. However, because you're looking at the patient as a whole, be careful about cofactors such as smoking, whether the patient is going to have simultaneous grafting, whether you're using multiple implants, and if you're using only short implants. These are cofactors which can influence the success or failure in diabetic patients. Now look at this condition for a patient who had an implant earlier and landed up with an abscess on the skin. We did a IND and sent for culture sensitivity, came back for Klebsiella pneumoniae, and we drained the pus. And then when we checked his glucose level, HbA1c was 9.4. So we don't have to panic when you have a situation like this. When the patient comes back to you, he's probably developed diabetes recently. So we go on, treat the diabetes and give them appropriate antibiotics, and then they recover very well. I'm just going to run through some of this infective endocarditis prophylaxis. Some of the guidelines have changed. It's used essentially for people who have prosthetic cardiac valves or prosthetic materials used in valve repair. Previous history of infective endocarditis, and of course, unrepaired cyanotic congenital heart disease. Please remember now, unlike the days when we were in undergrad, rheumatic heart valve disease used to be indication for prophylaxis. It is no more. A CABG or a pacemaker is not an indication for prophylaxis. Prophylaxis is also not needed for routine anesthetic injections, although you do come in touch with blood, especially if you have a direct injection into a vessel, or taking radiographs, or placing a removable prosthodontic or orthodontic appliances, shedding of deciduous teeth, and bleeding from trauma to the lips or mucosa. The antibiotic regime for this prophylaxis is amoxicillin, again, which was to be 3 grams, has now become 2 grams 1 hour before the procedure. clindamycin in case they're allergic to penicillin, 600 milligrams 1 hour before the procedure. Then let's look at blood pressure. Look at stage 1 hypertension. If you have blood pressure, a systolic pressure of above 160 or a diastolic pressure of above 100, you need to be careful. You need to get it under control before you can do an implant. Anxiety, affects blood pressure. So if you're going to do any patient who's a known hypertensive, please make sure that you use some stress reduction protocols. You could use some oral sedatives 1 to 2 hours before the procedure, or you could use intravenous midazolam. Make sure that the patient empties the bladder before he sits in the chair, especially if it's a long procedure. A full bladder can actually increase anxiety. And especially if the patient is sedated, it can be even more difficult. So make sure that the patient has an empty bladder when he sits down for sedation. And then look at what medications can influence hypertension control. Most of the patients are on medications for a very long time. So let's see how this can impact. Again, I'm not looking at any particular order. I'm looking at what are the common medicines that are being used. Aspirin, a lot of antiplatelet drugs, patients who have had a CABG, past cardiovascular event or cerebrovascular events, they are all put on some form of antiplatelet drugs, and commonly aspirin, ticlopidine, or clopidogrel. Most of these medicines, some of these are low-dose medicines, and we have to be careful about what you would do in such situations. If you have to do an implant or an extraction, the recommendation is that you wait for about 6 hours after the oral medication before you do the procedure. Important thing is you do not stop any medication. All the antiplatelet medications that the patient is on should be continued as it is. You do not stop it. There's a very common misconception among a lot of practitioners. So you need to control the antiplatelet drugs. Only thing, as a precaution, you give at least 6 hours time after the oral medication before you do the procedure. This was a very interesting study that was published, this timing part of 6 hours after oral medication by Yoshikawa in 2019. People on warfarin, what do you do for such patients? The INR of 2 to 3 is recommended for arterial and venous thrombosis, and 2.5 to 4 for mechanical heart valves. And this is the recommendation of the following societies. And this very important article, one of the landmark articles which shows the risk versus benefit of stopping warfarin, what's called the Wall Systematic Review, published in 2000. They reviewed 2014 surgical procedures, general surgical procedures, and showed that when warfarin was not stopped, there was no severe bleeding complications. Of course, there was some bleeding, but that could be managed by local hemostatic measures. When warfarin was stopped, however, 4 patients had fatal embolic complications. So this was a very important landmark article. And then they came out with some recommendations. And they said they classified what is a low risk treatment, moderate risk, and high risk. A low risk was at 1 to 5 teeth simple extraction. You see moderate risk 6 to 10 teeth, and high risk was more than 10 extractions. And they said in low risk, you can continue therapeutic warfarin. If it's a moderate or high risk, we do not have any significant data to give recommendations. So what you can do is convert those patients into low risk. Basically, you do only 1 to 6 extractions, 1 to 6 implants, and you can continue the therapeutic warfarin. And INR up to 3 is acceptable for such patients. In our practice, when we see a lot of these patients who are put on warfarin, you look at the INR, even with medication, it doesn't go sometimes beyond 1 or 1.5 or 2. So please check the INR levels for these patients and then do your measures. And of course, if you have any local bleeding, they can be easily controlled by these sort of measures. Alternatively, these patients can be put on subcutaneous heparin temporarily or as intramuscular heparin as outpatient procedure. The newer medications are these so-called direct oral anticoagulants as alternative to warfarin. Dabigatran is a thrombin inhibitor, which is given as a twice-a-day dosage. So it has a peak action of 1 to 3 hours. So when patients are on thrombin inhibitors, the recommendation is that you do the extraction 12 hours after medication. So basically, you try to give up more time after medication before you do the procedure. Let's come to some very interesting data that's come out. This systematic review and meta-analysis published in 2018. For those of you who are a little academically oriented and want to take some reference, please note this, because this is a very interesting article which showed what are the medications that can have an impact on, especially with regard to failure of implants. And then you'll see that this actually includes quite a lot of common medication that we use: NSAIDs, SSRIs, proton pump inhibitors, and bisphosphonates. The common NSAIDs which we use: aspirin, ibuprofen, diclofenac, celecoxib, naproxen. These are the common medications that we use, and all of them have an impact, and they are associated with increased implant failures. So alternatively, try to use paracetamol or tramadol. The only problem with tramadol, sometimes you can have an opioid-like effect and could be addictive. For gastroesophageal reflux, common treatment is proton pump inhibitors like omeprazole, pantoprazole. I'm sure a lot of your patients are on those. So look at alternative medications such as prokinetics or antacids and try to maintain a low BMI of less than 24. And I've seen some very interesting articles coming from, I think, Nagpur. One of the social medicine person, Dr. Jagannath Dikshit, he's come out with some very interesting data about how you can reduce GRD, reduce obesity, reverse diabetes, just by controlling the diet and going to what's called a 2 times a day diet. Anybody interested in knowing more about these things, look up his Jagannath Dikshit website. Very interesting sort of take on control of diabetes. A lot of patients today are on antidepressants, especially in COVID times. We've seen a phenomenal increase in this. These are class of antidepressants called SSRI, selective serotonin reuptake inhibitors, such as Prozac and Paxil. So these are also known to have been associated with higher implant failure rates. So when you have such patients, you can talk to their physician and see if they can be put on some alternatives, such as SNRI, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, and monoamino oxidase inhibitors. Now, conversely, patients who are on highly hypertensive beta blockers and ACE inhibitors actually have shown better outcomes for implants. So that's an interesting data for us. You know, if you look at these classes of medicines that most of these patients are on, and if they're on antihypertensives, you're already on a slightly positive wicket. So just be aware of these factors. What about steroids? A lot of patients are on long-term steroids for a lot of medical problems. However, the Mayo Clinic has shown that there's no adverse effects of steroids, but still you should exercise caution as far as the maxilla is concerned, simply because of the quality of the bone. Let's look at another interesting thing of osteoporosis. DEXA scan is considered to be a diagnostic to say which patients are osteoporotic or which patients are osteopenic. So a value of -1 to -2.5 standard deviation is considered osteopenia. and more than minus 2.5 standard deviation is considered osteoporosis. And of course, for these patients, you put them on medications, and then you also ask them to avoid smoking, avoid excess alcohol, control the BMI. These patients are usually put on anti-resorptive medications such as bisphosphonates, and also in addition to that, vitamin D and calcium as supplementaries. So many of our patients who are older patients, especially women, are put on bisphosphonates such as alendronic acid, and these trade names may be familiar for some of you. However, the trend is changing. More than bisphosphonates, people are using monoclonal antibodies such as denosumab, and also other medications such as teriparatide. What's the problem with bisphosphonates? Especially if you're on IV bisphosphonates, the chances of medication-related osteonecrosis of the jaw is as high as 2%, which is a big risk with any sort of treatment, especially if you're doing an extraction or a surgical procedure or an implant. You need to be very careful about if a patient is on IV bisphosphonates. With oral bisphosphonates, you are much safer. However, you still need to know that there are a slightly higher risk. Although today you can speak to your physician or the orthopedic surgeon who's put them on medicines and see if they can be on some newer alternatives such as teriparatide, abloparatide. Teriparatide is given as a subcutaneous injection like insulin, and it's got none of the side effects of bisphosphonates. So when you see such patients with bisphosphonates, please talk to the physician and see if they can go on to some alternatives which are also available today. CTX is considered a marker for osteoclastic activity. So if patients are on bisphosphonates, they look at the level of serum cross-linked C telopeptide, and then they say if the levels are less than 150 picograms, there's more indication that this patient may land up with osteonecrosis. So the patient who was taking bisphosphonates, one small test that you could do is using CTX analysis. And if the patient is on any medication, ask them to give a drug holiday. Ask them to stop the medication until the CTX level becomes more than 150 picograms per ml. However, you must be aware that there is a small additional risk of developing fractures. The patient has to be extremely careful. What about thyroid disorders? Patients who are hyperthyroid are sensitive to adrenaline that we use in our infiltrations and blocks. If they're hypothyroid, you have to be very cautious with sedatives. Immunosuppressants such as methotrexate, cyclosporin, again, which is used for a lot of medical conditions. The evidence for implant-related outcomes are conflicting. We don't have clear guidelines on that. What about hyposalivation, Sjogren's syndrome, etc.? It's not a contraindication. So implants do very well. In fact, we have a couple of patients in follow-up for more than 10 years, and we have got very good results for those patients. So survival rate is almost at 100%. Parkinson's disease, there is a slightly lower survival rate. For these conditions, there are really not enough articles that we can rely on to give us some guidance. And then, last but not least, a true titanium allergy. Of course, this happens. We have to be wary of patients who have any other type of metal allergy, especially in our country where people wear jewelry. So if they have any evidence of, or if they have a history of any metal allergy, be a little more watchful. There's a high likelihood that they may also have titanium allergy and reject your implant. Of course, there are tests such as skin patch test and a memory lymphocyte MELISA test, which can be done to assess this. So we come to the end of the first part, which is a medical history, which I think is very important for you to keep in mind when treating such patients. It also put you on a different level of understanding and comfort zone for the patient, because you're looking at the patient as a whole. You're looking at the patient as an entire entity rather than just looking at teeth. And if you ask them to do some tests like glycosylated hemoglobin, or for example, even if you want to be even more careful, you can do a free insulin level. A level of free insulin or fasting insulin level. A fasting insulin level is a much better, a fasting insulin level is a much better way to analyze or look at the diabetic control. You can ask for a DEXA scan, look at their osteoporosis or osteopenic individuals. So these are very important to analyze, and then look at the medication history, because that is also very significant. You've seen that so many of these medications can influence the outcome of an implant. So be very careful when analyzing and go through it in great detail. And then, of course, you go through the surgery of the implant and then go on to the final processes. So I'm going to take you right to the next end of the spectrum, which is where you can use technology to help patients. Quickly, I'm going to run through the fundamentals. Implant fixture is a titanium part that goes into bone, which osseointegrates, and then it has a smooth surface, which is for mucosal integration. And on top of that goes an abutment, which can either be straight or it can be angled, depending on how your implant emerges and what type of processes you're planning. And then you have the crown that comes on top of the abutment, which can either be a cemented crown or a screw retained crown. The implant osseointegration period is usually 3 months for the mandible and 6 months for the maxilla. These are all, standard conventional healing periods. But today, we have got much better designs. We have got titanium zirconia coatings. We have got surface modifications, which allows you immediate loading or early loading within 6 weeks. There are newer techniques, such as the all-on-4 zygoma implants, which allow you to splint these implants and load immediately. So although conventionally we wait 6 months for the maxillary implants to integrate and 3 months for the mandibular implants to integrate, with newer designs and newer techniques, all these things are changing rapidly. What about the age or timing of the implant treatment? You normally do an implant only after growth completion and maturity of the skeleton. So you wait for growth completion before you can place an implant. Again, this is conventional. But there can always be an exception to these. And one such exception is ectodermal dysplasia. Especially if the patient needs a restoration in the mandible. There is literature to show that they are shown as young as 3 years of age. So we had a patient of ectodermal dysplasia who was 5 years old. So we knew we could do that because most of the mandibular growth is complete by that age in a patient with ectodermal dysplasia. So he was wearing dentures, and of course his lower denture had very little stability and retention. So we could do 2 implants for him in the mandible and have an overdenture. So which led to much better retention and a much better quality of life. So this is what is possible today with newer technology and what we learned from the newer articles. Implant today is moved away from a completely surgical driven subspecialty to a prosthetically and aesthetically driven stealth surgery. And people are already predicting that this will be the future of implant dentistry. what's called stealth surgery or digital surgery. People certainly don't want implants, they want teeth. And you have to place the implant exactly in the desired position, which supports a better implant and gives better prosthesis mechanics. Why do you need to look at all this? So that you can have a long-term functional and a long-term aesthetic results. So this is for this reason only you need to do proper planning and use all the technology that is available. This essentially is reverse engineering. So when we start off, the standard of care for most implant placements is today taking a cone beam CT. And then you virtually plan the prosthesis and then back work towards planning the implant. And then you decide whether there's sufficient bone or insufficient bone. And if you have sufficient bone, so if you have sufficient bone, you would go ahead with implant placement. You can do either open surgery or a guided surgery. If you have insufficient bone, and then you would do open surgery and also do some grafting. So let's start with the cone beam CT. Although a lot of planning can be done with intraoral X-rays and the panoramic X-ray, the standard of care today is a cone beam CT. And what is the advantage of this cone beam CT compared to a conventional medical CT? One important thing is a much lesser exposure time, which means much lesser radiation. You can see that the radiation is 128 microsieverts average compared to almost 4 times in the CT scan. And the other huge advantage in cone beam CT is there is very little scatter when you have metal restorations compared to a CT scan where there is much more scatter. Now, you know that most of the patients who come will already have a pre-existing restoration or a metallic crowns or bridges. So if you have lesser scatter, it's obviously going to give you much more accurate measurements and your planning can be much more accurate. So a cone beam CT today is the standard of care, a gold standard compared, and not a CT scan. And the slices are also much thinner. You can go to as less as 0.1 millimeter slice in a cone beam CT. So to recapture, we have to design the processes, determine implant size and position, and determine the implant angulation. And if you have sufficient bone, you can do fully guided surgery or an open flap surgery. So this choice, whether you want to do fully guided surgery or an open surgery, is really clinician-centric. You know, there are certain situations where you can completely reliably do fully guided surgery, especially if you have enough keratinized tissue. If not, it's better to do an open flap surgery. If you have insufficient bone, you have the option of doing what's called a semi-guided surgery, which means you do the pilot drill with a surgical guide, and then you open the flap as an open procedure and add regenerative procedures because you do not have sufficient bone. You can already open the flap straight away as a full open flap surgery and add regenerative procedures such as a bone graft or a membrane and create more bone. Or you can use alternative techniques where you can use what's called remote anchorage like the pterygoids or the zygoma, a bone, and take support. So this is a situation where a patient is missing a central incisor. So you've got a scan, you've overlaid a prosthesis on top of it. So you match the prosthesis, the missing tooth in relation to the adjacent tooth for the contour, position, etc. And then you back work from here and see how much bone is there and what is the position of the implant. So you can see here that there is sufficient bone, there's good volume of bone. You can see that The thickness of the alveolar crest is quite good to take in a fairly wide type of implant. The height of the bone is also adequate. So once you determine that you've got enough position, enough bone for an implant, then you plan the implant, and then you also place a virtual abutment in its place. So implant and the abutment planned, and then you can see a straight abutment would emerge to the labial surface of the tooth. A straight abutment will come like this. Whereas if you put an angled abutment, you can take it down towards the cingulum side. So all this can be planned well ahead of time. So you can see that your decision of the implant placement, the decision of the abutment, whether it's straight or angled, can all be made in this planning stage. Can we do this even for a full arch? Certainly we can do that. So you have an articulated model, and then you have what's called a duplicated denture, which is then to which you can incorporate some radio-opaque markers. You can use gutta percha, zinc phosphate, punch some holes, and then fill it up with radiographic markers in multiple locations. And once you do that, you can see that it's done not only on the occlusal surface, but also on the palatal and the labial surfaces. And this is called the radiographic guide. Now, using this guide, the patient keeps it in the mouth in occlusion, and then a CBCT is done. So now you've got a good idea of the soft tissue interface with the denture and the underlying bone. You can see that these radiographic markers show up very clearly on the scan. And once you have these sort of markers showing up on the scan, you can, with the dual scan, you can now impose a denture. You can superimpose the prosthesis on top of the underlying bone, which can then let you evaluate the position of the bone in relation to particular teeth. For example, what's the bone present under the incisor or the canine region or the molar, the relationship to the sinus, etc. And then you could select the implants, and then you can select the abutment, almost like the same way that we chose the abutment for the individual teeth. And then you go on to planning it. The file format for these are the STL files, what we call as a surface tessellated language, or STL file. Of course, there are other file systems, but the most common ones is the STL file. And then once you've got the superimposition, you start the planning. And you can see clearly how the implant position in relation to the buccal and lingual cortices, in relation to important structures such as the inferior alveolar nerve. And there also you look at the position of the implant and the abutment and the crown. You also look at the space that is available for your prosthesis. Many a time people make a mistake of placing these implants very shallow at this point, and then do not have enough space for the prosthesis. So it's very important to plan the position of the implant three-dimensionally. And then you superimpose a crown on top of it and see how it occludes with the opposing dentition. And here you can play around with this planning and see for the emergence of the prosthetic screw. So you look at the labial side, you look at the occlusal aspect, and you can see how the emergence of the prosthetic screw, you can of course move it a little more lingual if you want, or a little more distal, depending on how much of material you want in the other parts of the tooth. And then using this data, we fabricate what's called a surgical guide. So this is to aid in placing the implant in a very, very precise manner. So the fabrication of the surgical guide is then done using all this data. The surgical guides can be categorized as follows. They can either be completely bone-supported surgical guides, or they could be tooth-supported guides or mucosa-supported surgical guides. So each has a role and each is used in different situations, which I can't go into now. But just be aware that these have bone-supported, tooth-supported, and mucosa-supported guides. And there are some parameters. For example, what should be the minimum height of the sleeve? Because you do not want your drills to go wobbling. When you plan it very precisely, you need the sleeve height of certain height, minimum dimension. For example, you need at least a 5 millimeter sleeve height. Anything lesser than that can introduce some inaccuracies. The materials make a difference. The sleeve offset is different. So you can see that a lot of planning goes into making a surgical guide. And once you have a guide like this, you can be sure that the positioning of an implant is going to be exactly as you planned, using all the data from the CT scan and the intraoral scanner. So you merge the data from your CBCT and your intraoral scan, and then you come to a situation like this where you have the very nice surgical guide. And this guide is now placed and used for implant fixture surgery. So you can see that this is fitted on the teeth and it is completely seated. You have a viewing window just to make sure that the guide is fully seated, because if this is not fully seated, then you will introduce inaccuracies. So it's a fully seated guide, and then you can see the position of the where you got to drill. And once you do the implant site preparation, this is what's called a fully guided surgery. We have not even opened the flap. We have just made a keyhole punch. And this is simply because the patient had enough volume of bone and had enough keratinized tissue. If you do not have enough volume of bone or enough keratinized tissue, you cannot do this punch technique. So this is a fully guided surgery where you just punch and then you can place the implant, and you can see that the position of the implant is appropriate, is far away from the nerve, and is placed deep enough so that you have enough space for the prosthesis. So that's very important. So I'm going to take you through maybe one more short video. Just give me a second. So we have the video which shows the we have taken out, this patient had some deficient bones, so we had grafted earlier, and what we took out now was the membrane, a titanium reinforced membrane, and then we are using the stent. So the stent is now used. To just check the position of the pilot drill. I'm using this as just for the pilot drill, and then we have opened the flap, and once I open the flap, we drill the position. And you can see again, we use a direction indicator. So when you have a very restricted space like this for central and lateral, it's important that you have very accurate planning, otherwise you will not have an ideal prosthesis. And this is even more important for a patient with a high smile line. You need to be very, very careful with the positioning. You need to be parallel. You need to plan your prosthesis. And based on that, you reverse work and place the implants. Now look at this situation where the patient has missing molars and the sinus has dipped in quite a bit. So this panoramic version of the CBCT shows that the molars are missing, the sinuses are expanded. So this goes through the same process. We use a digital intraoral scanner to scan for the data. You have a CBCT, and you merge both the data, the CBCT data and the intraoral scanner, and then plan the implants. And then you can see that some of the implants, the bone height is not enough, so we need to plan maybe a couple of millimeters, 2 to 3 millimeters of implant is going into the sinus. So that has to be planned as what we call as an indirect sinus lift. So once you've done this planning, then you look at it more carefully and closely and see whether we need. You can see that this implant is almost about 2 to 3 millimeters within the sinus. And this can be done as a closed technique. And once the sleeve is placed and the process is also planned, you got the whole range of instruments that you need to do the guided surgery. So for me, this is also a very interesting thing to show a patient about the planning, the meticulous planning that goes into the treatment plan, and the number of drills that we use. It can be a very good patient education tool. So once we have the emergence of the prosthetic screw, you've determined where you want to place it, you can then fabricate the surgical stent based on this prosthetic position. So we already planned the processes. And for instance, if I want this site to be changed to a 3-unit bridge, instead of 2 molars, if I want to make it as 3 premolars, I can do this. I can move this position a little away and then plan for 2 implants, but a 3-unit bridge. And then the surgical stent is fabricated like this. And then procedure is finished. What it does is, a surgeon with maybe 20 or 30 years experience and an implantologist with even 2 or 3 years experience can get identical results using this technology. So that's a very interesting aspect of this technology, making it so much user-friendly and making it almost idiot-proof as a technique. It improves the standard of care, and very important is there is more litigation protection. Today is a litigious society. Almost 50% of litigations are surgical and implant related. So you need to be very careful about this. Look at this situation in a partial edentulous situation. Patient has just 2 teeth left. With a nice stent like that, you can make very accurate implant placement and prosthetic position. And this is the important thing. The prosthetic position of your screws, the prosthetic screws are in such a nice arch form. You do not have any problems of oral hygiene issues or overhanging margins, etc. And then the same thing can be also used for pretty extensive implants, such as zygoma implants. So when you do single zygoma implants, when there is very little maxillary bone and you want to restore the prosthesis, a full arch process in the maxilla, you can use what's called zygoma implants. You can also use what's called a quad zygoma implants. So when you have almost 0 bone in the anterior maxilla, you can use 2 zygoma implants on either side. Of course, these are a little more extensive surgeries which has to be done under a general anesthesia. But what you can see is when you use a guided surgery, the positioning of these even so-called difficult implants becomes so much more accurate. And you have enough distance between the apices of these implants, which is very difficult with freehand surgery. So guided surgery can be a real boom in these sort of situations. And again, see how those 4 implants are in an ideal prosthetic position. There's no point putting in implants where you find bone and then having overlapping processes or a process with a large buccal cantilever. So these are the advantages of using a guided surgery. From patient's point of view, safety is a very important aspect. Poor visibility in places such as the pterygoid or zygoma, including the anterior mandible. People may say, what's the difficulty in anterior mandible? Anterior mandible can be one of the very difficult areas to treat. In fact, whatever mortality has been reported in implants is all related to anterior mandible. So you need to be extremely careful of the anterior mandible when you treat. It's simply because of the resorption pattern of the mandible. You can see how the mandible is completely resorbed in a fashion that if you come with an implant and go straight down, you'll go into the sublingual and submandibular spaces. And these sort of complications have been reported, which are fatal or at the best life-threatening. So these sort of patients require emergency intubations. So you can see again where guided surgery can be very useful in such situations when you're planning. This looks as if these implants have gone through the nerve, but actually they have bypassed the nerve on the lingual side. So a guided surgery can be really useful in full arch situations. And it can also lead to a very nice anterior-posterior spread, which gives you very less cantilever. Certainly, it leads to much more precision. You can see that these two implants, these X-rays are taken almost 15 years apart. And you can see that the bone levels have maintained very well. So this was among one of our first few guided surgeries. You can see how they really help in maintaining the bone levels also. Certainly predictability when you have an overdenture that's needed for a little older patient. So you have, if you look at this picture, you may say that these implants are too lingually placed in relation to the ridge, but this is precise positioning as far as the process is concerned. So you'll see that with this, we make an overdenture, and this can lead to such a boom for a patient who has very poor retention in the lower arch and very resorbed mandibles with the mental foramen is almost at the ridge level. So this is a very useful procedure. The time to teeth, that is from the implant placement up to finalizing the processes, can be reduced tremendously because of this. I alluded to this earlier that this will also lead to a de-skilling of the surgeon and the surgery, but that's not going to happen with all technology. You see artificial intelligence, machine learning, all this is certainly going to lead to a de-skilling of the surgeon, but makes it safer for the patient. However, like I said, implantology from single tooth to multiple teeth can be a great thing to give a new smile, a new tooth, but it can also change lives. How can we influence changing lives like this? Syndromic patients like this young girl in the mid-20s, and look at this panoramic. CVCT has very little bone, very large sinuses. You have no choice but to do implants, and that to some advanced level of implantology. So when you change a patient like this, you're changing their lives. Syndromic patients with two teeth hanging in, again a young girl. So you'll see more and more patients who are younger who benefit with this treatment. Again, a rare condition such as primary failure of eruption. So this patient came with situation like multiple impacted teeth. We investigated her, and then the final diagnosis was a primary failure of eruption. Again, a younger patient. So our thing of implant patients being older patients is not there anymore. We feel a lot of patients who are younger who need this sort of treatment. We do multiple implants, all-on-one technique or zygoma, and then restore them. So in these ways, we can really change a patient's life. So you as a doctor, I think, can make a huge impact on patients by doing implant treatment. I'd end with this quote from Aristotle, who said, life is a gift of nature, but the quality of life that you give to a patient is a gift of your wisdom. Thank you very much for your kind attention.
Thank you, Dr. Gunashilan, for an excellent presentation. You made such a complicated process so simple. It was so inspiring for the youngsters. In fact, a lot of questions I have been looking into, and they'll be definitely inspired by your presentation. And it was both covering the surgeon's perspective as well as a prosthodontist perspective on implants. And as you know, it is very customary, and you will be happy also to answer some of the questions from the participants. Now, for the participant, I beg your excuse, it is very difficult to cover all your queries, and some of them also are too personal. But however, we have picked up some questions that will be helpful for participants as a whole. So Guna, people have asked, how do you learn for proper implant placement?
How do you learn?
How do you learn? They have asked, how do you learn doing proper implant placement?
I think today implants have been practiced extensively all over the country. I think they need to find a good teacher. And you find good teachers in every part of the country. Every city has good teachers, good long-term. See, there are the teaching is also undertaken in a lot of colleges today, implant training as part of the curriculum. But those who have missed it can always go to some well-run implant programs, and maybe over a 6 months or a 1 year period or 2 year period programs. Of course, a lot of commercial programs are run by implant companies, but those will be very focused on techniques or their own system. You need to learn the science of implantology, and I think that is very important. And that should come from some courses run by big academies or by universities and international bodies like the ICOI and ITI. A lot of them run some very, very good academic programs. And then combine it with some practical classes, because you need to get hands-on experience. And that's why I think you should look at some good mentors. And every region of the country has good mentors, very good clinicians. I think you should find the right person and get mentored by them.
Thank you, Guna. But a linked questions, though it has come a little late and on, but many of them are asked about the future of doing implantology. And very simply, they have asked whether a diploma in implantology or a MDS.
Well, I have been a dental council member before, and we have discussed this in the council. I think it's a very appropriate body to ask, but not the appropriate person. I'm not the right person as of now. But Dr. You're there, and a lot of members who are very up to date are here. I think that's the need of the hour, no doubt about it, to introduce a program that will be recognized by the council, a 1 year program or a 2 year program or even a 3 year program maybe. I think it's certainly the need of the hour, because implantology is one of the fastest growing subspecialties of dentistry all over the world, not just here. So there's almost a 20%, jump in implant usage and practice year on year. So this is one of the most rapidly growing and rapidly changing subspecialty of dentistry, and you saw that it goes through so many aspects of dentistry, right from your medical history to the oral surgical part, the diagnostic part, imaging part, and then the planning part, and then your prosthetic part and long-term maintenance part, and then the soft tissue, perio issues, aesthetic issues, grafting. Every aspect of dentistry is covered. So I think it is the future is really bright for implantology, but the future lies in the person who takes up the job. There's quite a famous quote: "There's no future in any profession. The future lies in the person who does the profession." So I think they must take a clue, train themselves well, arm themselves with an extra diploma or a degree or at least a long certificate from a good university before they start practice.
Thanks, Guna. And many questions are on basic pharmacological agents, action of many medicines on the health and all, which is very difficult to cover. But many people just wanted to know about the controversy of putting implants in patients with aspirin in particular. Would you please throw some light on it?
See, today there's no controversy. if a patient is on low dose aspirin, 75 milligrams or 81 milligrams, you continue the aspirin as it is and then do your treatment, whether it's implant or extraction. Only thing, if you make sure that you give sufficient time, you get at least a 6-hour gap after the medication before you do the procedure. That adds to the safety. And then once you finish the procedure, you make sure you have good hemostatic control. So whatever local measures, you would use some adsorbed gel, you would use some oxidized cellulose, you would do suturing, you would do some thermocautery. So the important thing is not to stop the aspirin. And I know even till today, I have cardiologists and physicians telling patients stop it for 3 days, 5 days prior to the procedure. I write back to them, I put it in writing that I do not need the patient to be reducing or stopping aspirin. If you insist, I will stop. Otherwise, today, our literature, and I actually sometimes give them a small reference, like this Wall's article or some new systematic reviews. And then a lot of them actually accept it, and then they let the patient continue the aspirin. But having said that, I know there are a few physicians and cardiologists who still insist on stopping it. But then I have a written documentation in my hand saying that they have asked them to stop. I have not asked them to stop. So this is what is very important in today's day because of litigation protection. You need to document things. And I can assure you, we have done enough implants, enough full arch implants without stopping or reducing aspirin. And the literature support is there for you. So please be aware of this. Thank you.
I agree to your answers also. And you talked in between about this allergy. So is there any option for this? Any other option to avoid allergy to these metals?
Good question. Today we have an option of a non-metallic implant, which is a zirconia implant. So zirconia is now a great option. We were not using it much earlier because it came as one part implant. That is the implant fixture going into the bone, and the abutment part was one piece, which made it very difficult to control the angulation of the prosthetic screw, etc. But today, we have what's called a two-part zirconia implant. And that is a huge boom for people who are allergic or where you suspect an allergy. It's also very useful in a aesthetic area, high smile line, maxilla. When you think, the aesthetic score, you look at the aesthetic score and then decide on that. So zirconia implants have a great future, and they're already available today. The only negative thing about them is the cost factor as of today.
Thank you, Guna. People talk about nowadays about pterygoid implants. Can you throw some light?
It is definitely not for the beginner. If you have done, enough implants, and if you're probably a maxillofacial surgeon, then you can venture into it. However, I did mention briefly that it's a blind spot. So with technology, with using guided surgery, it may be a good option today because it's a good supportive bone. It can be used with guided surgery. But without guided surgery, I'll be very, very wary of using a pterygoid implant. And even from the prosthetic point of view, the pterygoid implants usually emerge so far posterior in the maxilla that they can be a big challenge from the prosthetic part of it and hygiene maintenance, etc. So pterygoid implants is definitely at a later stage of your growth in the field of implantology, and certainly preferably with the help of a guided surgery.
Thank you, Guna, again. There are very long list of questions, but again, with some selective questions. Yes, somebody has asked whether you have any security problem going through the security checkups in the airport with these dental implants.
Not at all. Not at all. It's nothing more than the titanium plates that are used for fracture fixation and all that. It doesn't beep. It doesn't have no issues at all.
Thank you. Again, there was a question. Is there any difficulty in the future taking MRIs if you have dental implants with you?
Not at all. Actually, no issues at all with MRI, taking MRI later on.
Oh, that's great. And some people have asked, yes, there was a question but he didn't understood what is the meaning of implants are predictable. Can you explain for him?
Implants are predictable.
Yeah, can you explain? I mean, probably he has missed some part. Yes, definitely implants are predictable. So, and he says again, which is the best implant material in the current clinical practice?
Okay, I'll answer the second question. The implant material is, as of date, the standard material is titanium, commercially pure titanium, CP titanium, grade 4, grade 5, what is called titanium 6Al4V, 6 parts of aluminum and 4 parts of vanadium. So that's a commercially pure titanium is the material of choice. Now with zirconia coming in as an option, so zirconia as an implant material is also a great option today. So these are today the materials that are used for implants. When I say predictable, the long-term predictability of an implant or survival of the implant will depend not just on anatomical factors. It will also depend a lot on biomechanical factors, oral hygiene maintenance, these sort of issues. So when you plan properly, you look at the quality of the bone, the quantity of the bone, the location of your implant collar, the amount of bone that's available at the level of the crest of the implant. You need at least about 1 to 1.5 millimeter bone there. You need to have keratinized mucosa at the emergence of the implant. So these are the things, the planning part, if you do it adequately. And how do you plan adequately? Using CT scans and using intraoral scanners or CT scans, and you take good models and make processes and then do a dual scanning technique. So when you do all these precautions and do an implant, you have a much better long-term success and predictability. That's what I mean by predictability of the implant.
Thank you, Gaurav. A little away from this monotonous question, somebody else probably is very scared. He has asked, can sunlight kill coronavirus? He's very optimistic.
What? Say again?
Can sunlight kill coronavirus? A little away from these regular topics. Can sunlight kill coronavirus?
Kill coronavirus?
Yeah, he wants to know.
If that was the case, we won't have coronavirus in India. We have enough sunlight. No, certainly not.
Yeah. Thank you, Gaurav. You have covered these topics excellently. And one very personal question to you by many. And I also was in doubt whether I should ask it or not. But since there was lot many, why did you pursue BDS after MBBS? It's very personal. You can answer them personally if they write to you.
Yes, I'll probably answer that personally.
Okay. Thank you, Gaurav. It was really excellent coverage of the topic and
Thank
all.
you.
And now,
thank you again for your kind attention and those wonderful questions. I really appreciate the time that you spent on a Sunday evening and listening to my presentation. I look forward to seeing you, most of you, sometime or other. Thank you very much. Good evening.
yeah, I'm sure we have a lot of participants attending this seminar, this webinar. And again, I'm happy to say that the topmost college of participants on last webinar on 16th August, I'll be happy to read them again. Sardar Patel Postgraduate Institute of Dental and Medical Science, Lucknow. Siddhapur Dental College Hospital, Gujarat. NIMS Dental College Hospital, Jaipur. Indraprastha Dental College Hospital, Ghaziabad. Vishnu Dental College, Bhimavaram, Andhra Pradesh. And next, we'll be happy to announce here that the next webinar will be on 30th August 2020 at 4 p.m. The topic would be on dental caries, the current concept of dental caries, It will be presented by Dr. Srinivas Vanaki, Principal and Professor, Oral-Pathology, PMNM Dental College and Hospital, Bagalkot, Karnataka. And the session will be moderated by Dr. R. Radhakrishnan, Director, Department of Oral-Pathology, Manipal Academy of Higher Education, Manipal, and would be very happy to get as many number of participants as we can get. Now, at the end of this webinar, I would like to thank our esteemed President, Dr. Dibyendu Majumdar, whose vision was to promote learning, and I'll be happy to thank Dr. Sabyasachi Saha, who has already been in support for all these activities, and I'm extremely grateful to the DCI team and the technical support team, by help of whom we have been able to conduct this webinar very successfully. And thank you very much, and looking forward to see you very soon. Namaskar. Thank you all. Jai Hind.
Thank you very much on my behalf also. I would like to record my special thanks to the Dental Council members, the EC, and in particular to the President, Dr. Majumdar, for reposing faith in my teaching concern and interest, and giving me this opportunity. I don't think I've ever spoken to an audience of more than 10,000 people at one go. It's a very humbling experience. So I'd like to thank the entire team on DCI led by Dr. Majumdar, the EC and the members, and Dr. Saha, who has also been instrumental in coordinating everything. And I think more important, I'm very happy that some of the participants brought up this question of implant education and a diploma or fellowship. So I think they're given a lot of homework for the entire Dental Council now to work on. I'm very happy about that. And I'd like to thank my coordinator, Dr. Indubhushan Kurt. We go back many, many years, and a lot of trust and respect, mutual respect between us. Thank you, Indu, for taking me through this. And Dr. Virinder Goyal, thank you for your absolute professionalism when we went through this program day first day, the rehearsal. I'm really impressed, and I think the success of this program is largely due to your efforts, and certainly at the background, Mukesh, the entire technical team. And hats off to you for taking this to a different level of education. And this is the future of education, I think. And I think the Ministry of Health and Family Welfare, Government of India, has also taken a right step forward in this aspect. So thank you very much again. It's been a wonderful experience. I just wish I could have seen each one of you on my screen, but I'm sure I'll meet all of you sometime or other. Thank you very much. Bye-bye.
Yes. Thank you all. Thank you all participants and the team again, and looking forward to see you soon. And with this, we declare close of this webinar. Thanks again.